Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Roche.
Hello, I'm Christiana Dina. I'm a retina specialist based in London. Welcome to this program titled Diabetic Macular Edema, Express Q&A on What's New. Joining me today is Ian Pearce. Would you like to introduce yourself, Ian?
Thanks, Christiana. I'm a retinal specialist from Liverpool, UK.
So today, we'll give you some quick-fire answers that can help guide your decision-making for the management of diabetic macular edema. We'll cover biomarkers, biosimilars, second-generation agents, drying and durability. Ian, should we get started?
So I think the first question is what do you actually mean by a biomarker in the context of retinal disease, and particularly OCT and diabetic macular edema? You have 1 minute and your time starts now.
No pressure. So, a biomarker is a measurable indicator of what is happening in the body, especially in relation to disease or health conditions. For instance, blood pressure measurement, that's a biomarker. In retinal disease, OCT biomarkers are specific features on OCT imaging that reflect disease presence, severity, or progression. They're obviously very popular because OCT, as you know, is quick and non-invasive. In diabetes, other biomarkers of disease such as HbA1c, blood pressure, duration of edema, of course matter, but OCT being non-invasive and quick is now extremely important in the way we manage diabetic macular edema.
So you've mentioned many biomarkers there. I mean, I think the latest reports are talking about maybe having 75 biomarkers for diabetic macular edema. But what biomarkers do you think are most relevant in OCT assessment of diabetic macular edema? You've 90 seconds for this one.
Right. Before I go to that, you did not congratulate me for finishing the first one 20 seconds or so early, right? But yes, I will be able to do that.
90 seconds and counting.
Thank you. So when we think about OCT biomarkers, there's a plethora of them, as you've mentioned. But the most well-studied one is central retinal thickness. This has been studied really from the advent of OCT in diabetic macular edema, and in fact in retinal diseases. And CRT, so central retinal thickness, is essentially the quantitative measure of thickness that reflects the amount of edema at the central subfield. And it's a measure of the anatomy, and indeed can be a measure of anatomical response. Others include intraretinal fluid, which is closely linked to reduced visual acuity and can be harder to treat than subretinal fluid. Subretinal fluid, which is easier to resolve and can be linked potentially to better visual acuity or prognosis. And then we have more emerging biomarkers, which, like all biomarkers, OCT biomarkers anyway, we do need a lot more work around validation, but these are emerging ones that appear to potentially tell us a little bit about severity of disease or response to treatment. And they include hyperreflective foci, which are small bright dots on the OCT and thought to be markers of inflammation and chronicity, ellipsoid integrity, which basically reflects photoreceptor health and may be linked to poorer visual acuity prognosis, drill, which is disorganized retinal inner layer, and exudates. There's also epiretinal membranes, but I can see I'm out of time, and I know you're going to hold me to that. Now it's my turn to ask you, what do you use most in your clinic? Do you use any of these biomarkers at all when you're treating your patients?
Well, I think, Cristiano, we see all of those biomarkers on a daily basis, but some of them are difficult and some of them are easier to interpret. So let's take, for instance, ellipsoid zone integrity. Well, when somebody comes in at first and they've got a very swollen retina, it's not easy to assess that ellipsoid zone integrity. And I think that's one of the difficulties we face. So I think some of them that we see are difficult, but there are key ones that I think we use on a day-to-day basis. basis. And the classical example of this is central retinal thickness. And I think central retinal thickness in terms of how we not only just the central 1 millimeter, the central foveal thickness, but actually the volume map as well. I use that all the time, and I'm sure you do, and many of our colleagues will use this regularly. When you're seeing a patient with diabetic macular edema, you're looking at that as a change in that from baseline to the next injection or the next treatment, and so on and so forth. And so if there's a delta change in that biomarker, the central retinal thickness, or the volume map shrinking, I often feel like it's the red hill with snow on the top, slowly melting away as conditions are improving. I think those are the things we use. I think all the other key biomarkers that you've mentioned, I think hypereffective foci and exudates and the ellipsoid zone integrity and drill are all critically important, but we still need to make sure that we understand them, validate them, define exactly what they are. Is ellipsoid zone integrity, is it 100 microns? Is it continuous or discontinuous? All these things need to be studied a lot more to make sure that they can help us in our individualized care of patients.
And you're out of time. Now it's my turn to ask. We have biosimilars. These are new on the block for retina, and certainly biosimilar aflibercept is relatively new in the UK and in many jurisdictions. What can we expect from using these agents when we're treating our patients with diabetic macular edema compared to our originators? You have 60 seconds here.
So I'm personally, we started to use biosimilar aflibercept in our own practice, and I think what we're seeing is what we expected, which it's identical results to the originator 2 milligram aflibercept. Now, that's not a surprise. It's a biosimilar product. It's what you would expect. I think we have to be cautious and we have to audit our results and make sure that we are still getting the same results and that there are no adverse events from these individual biosimilars. But I'm not expecting them. We've not seen them in our unit at the moment, but I think it's something that we need to keep, cautious of it. But I don't see any reason for not using the biosimilar. If you're going to use 2 milligram aflibercept, why not use the biosimilar?
So we are using them as well, as you say, and we haven't seen any adverse events either. It's early days though. However, I suppose the question is really whether we should be starting with this first generation biosimilars, and there are many advantages to that, cost and so on. Or should we be starting with the second generation agents?
Well, what do you think? I mean, do you use with biosimilar as your first line, or do you think we should be using the second generation from first line?
The point is, we don't have level A evidence for any of this. What we do have in terms of a comparator to tell us which might work better are the head-to-head phases of the registration trials, both for faricimab, which is one of the second generation therapies, and aflibercept 8 milligram, which is the other. So really, we need to look at that data at the head-to-head phase and then see whether that tells us anything at all about which is better. And when I think about the head-to-head phase, the Yosemite and Rhine registration trials, they outdate or predate the aflibercept 8 milligram trials by 2 to 3 years. So of course we know a little bit more. We have more post-hoc analysis, and one of the post-hoc analysis done in that looked at the proportion of patients without intraretinal fluid at week 16, which is the end of the head-to-head phase, and showed that the eyes on the faricimab arms, so the treat and extend arm and the fixed dosing arm, had significantly less intraretinal fluid than the aflibercept arm. Importantly as well, over time, that difference was maintained at all time points out to the end of the trial. In addition, when they looked at the proportion, the time to first absence of intraretinal fluid, the eyes on the aflibercept arm, so the 2 milligram arm, actually achieved this first absence 40 weeks later than the faricimab arm. So I think that sort of data for me tells me that we're getting to drying quicker with faricimab than with the 2 milligram. And this is also corroborated by the macular leachate data, which is another post-hoc analysis done from the Yosemite and Rhine, which showed the macular leachate was significantly less in the faricimab arm down their aflibercept arm.
Yeah, and I think your point about those are the matched phases of the study, and there was clear benefit. I think one of the things that we've seen from the photon study with 8 milligram aflibercept is that by quadrupling the dose of the aflibercept from 2 to 8, we didn't actually seem to get that change in the central retinal thickness over that same matched phase. That's surprising, I think, because the results of the overall study seem to be better and favour 8 milligram over 2 milligram. And I think in clinical practice, I think we're seeing that as well. But the facts are at the moment, we can only look at the data we have. And at the moment, over the matched phase, faricimab outweighs 2 milligram aflibercept, and 8 milligram doesn't appear to have a better drying. Yeah, exactly.
Based on what we've got at the moment. Great.
So what are the realistic targets for fluid in diabetic macular edema, and what would prompt a change of treatments? I mean, do you decide that at an early period, maybe after 3 or 4 months, or do you wait a lot longer? You've got 90 seconds on this.
I'm going to try. So as I said, we know that the registration trials often try to simulate what we would do in clinic. Particularly now that most of the world is actually using treat and extend regimes, but that can be difficult. However, when I think about what I do in my clinic and what most of my colleagues do, it's really about trying to achieve the best vision we can or the best function we can with improved and then stable anatomy. So ultimately in diabetic macular edema, my aim is to get as high as possible visual acuity and as little as possible fluid, and then start extending, which means I will tolerate residual small non-foveal cysts whilst I start to extend. Importantly, though, the key here is if you're still seeing improvement in vision or reduction in CRT or macular volume, as you mentioned earlier, you should keep treating. And then when you're stable, then you start extending. That's pretty much what I'll do. And then to your last question about when I will start to consider changing. Well, if the fluid is still persistent in the center, I will start to think after about 6 to 9 months, maybe we've got to change treatment. If the vision is worsening, if I'm unable to extend beyond 4, 6, 8 weeks, because with the second generation therapies, we're now quite familiar with 12 weeks, 16 weeks. If I can't get to those sort of long intervals, I start to think it's time to change. And now to you, is there an advantage to using a second generation first line over starting with a first generation in terms of durability in diabetic macular edema? You have 2 minutes.
Yeah, so this is a very difficult one. So thank you for this. The difficulty is that there isn't, as you alluded to before, having that direct matched control is difficult from first generation to second generation agents. Now we've got it in those first few weeks, the match phase, but a long-term benefit is much more difficult for us to find out. The post-hoc analysis with biomarkers say that if you actually seem to get better fluid control earlier, you get a better outcome. I don't think that, again, is a surprise to any of us. I think if you're doing well at the beginning, you're likely to be doing well at the end. And we've seen this both in the Yosemite and Rhine trial in further post-hoc analysis, whether you look at central subfield model itself and just look at for the fluid measurements, or whether you look for the absence or presence of intraretinal fluid and subretinal fluid. Whichever it is, if you have a treatment-naive patient with relatively low baseline CST or low fluid in the compartments, either IRF or SRF, you get a good result initially, you'll get a better result at the end of the trial, either 6 or 12 months down the line. And that early control of intraretinal fluid, as I say, I think we've known for a long while, but the more data we have, the better we're able to analyze it. And I think what we've been able to see in those patients where you have a significant reduction of intraretinal fluid in the first few weeks of treatment, what you actually get is a better anatomical outcome and a better visual outcome at time points going forward. And again, I don't think that's a surprise. I think if you've got a patient who's doing well, they will do well. I think what we're looking for in biomarkers is to see, are there some other clues to try and predict above and beyond the intraretinal fluid or subretinal fluid? And I think that's the key. And as I said before, I think the issue is that we need to define it and we need to measure it, and we all have to be doing the same so that we can actually understand this further.
Absolutely. So Can real-world data help shed any lights in terms of which to start with first generation or second generation therapies? Now, this is our last question, and you have 90 seconds.
Well, it's always important that we see what happens in the real world, not just on the pivotal trials. But I think what we've been very surprised about with these second generation agents is that actually the great results we saw in the trials, whether they be for faricimab or for 8 milligram aflibercept, have actually been reflected and similar in real world data as well. And I think that's been better than we expected, because we know that in a clinical trial everything's very structured, but in the real world it's such a heterogeneous population we're dealing with that it's actually surprising that you're getting those similar results. Now, whether that be with faricimab or 8 milligram aflibercept, we're getting increased durability of the agents. That's reflecting as a reduction in the number of injections for patients as you go through the first and second years of treatment. And we're seeing that that's a benefit for patients, it's a benefit for our services, and it's a benefit for the health economics that we see. And I think that's been a surprise, how good these real world studies and how similar they've been in all corners of the globe and how similar they've been to the pivotal trials.
I couldn't agree with you more. I think that in general, you're right that we want to be quick to drying so we can extend out as quickly as possible for our patients. Now, our time's up, Ian, and thank you so much for a great discussion. I can quickly summarize what we've discussed here. We've talked about biomarkers, in particular using OCT biomarkers as a way to understand the disease we're treating and the response to treatment. We've talked about biosimilars, which are new agents, and what they bring to the table. We've talked about durability and whether to start with first generation therapies first or second generation therapies. And then we've talked about the value that real world data can bring to the table to enable us know how actually these therapies work in the wild with our all-comers population. And you've kindly also mentioned the need to validate biomarkers because that will help us better individualize therapies for our patients. Thank you again, Ian, for a fantastic discussion, as always. And thank you for your attention. Please continue to answer the questions that follow and complete the evaluation.